My name is Stella, and I was the Nuclear Medicine Registrar at the Royal Adelaide Hospital last year. I'd like to present the findings from our study, which looked at the use of DOTATATE and FDG PET to distinguish between typical and atypical lung carcinoids using surgical histopathology as the gold standard. Our team members have no conflicts of interest to declare, and our study was approved by the Ethics Committee of our institution. Pulmonary neuroendocrine tumors account for 20 to 30% of all neuroendocrine tumors and up to 2% of lung malignancies. They are a heterogeneous family of neoplasms classified into 4 histological variants: typical carcinoid TC, atypical carcinoid AC, large cell neuroendocrine carcinoma, and small cell lung carcinoma. Pulmonary carcinoids are well-differentiated nets and are classified as typical or atypical. Typicals are low-grade malignant tumors with less than 2 mitoses per 2 mm², and atypicals are intermediate grade with 2 to 10 mitoses per 2 mm². The distinction is prognostically important, as atypicals have a shorter 10-year survival rate of 35% compared to 56% for typicals. The combination of gallium dotapeptide and FDG PET scans offer a non-invasive method of evaluating nets. Several publications have demonstrated the value of the combined scans in preoperative assessment of pulmonary carcinoids. Our study has been modeled after the 2015 study by Lococo and colleagues, which will now be summarized prior to sharing the results of our study. In 2015, Lococo and colleagues undertook a multi-center study which showed that evaluating the combined gallium dotapeptide and FDG PET scans could discriminate between typicals and atypicals. Their findings were as follows. On qualitative assessment, typicals had a higher affinity for gallium dotapeptide and atypicals had a higher affinity for FDG. On semi-quantitative assessment, they noted that the median SUV max for the primary tumor was statistically significantly higher in atypicals using FDG and higher in typicals using gallium dotapeptide. For the FDG scans, liver was used as background correction, and they found a statistically significant higher value in atypicals. For the gallium dotapeptide scans, the spleen was used as background correction, and a higher value was noted in typicals. They also noted that the ratio of primary tumor gallium dotapeptide SUV max to FDG SUV max was statistically significantly higher for typicals, and that this ratio was the most discriminative index for predicting typicals. They also performed a receiver-operator curve analysis and noted that a ratio of greater or equal to 1.19 predicted typicals with a sensitivity of about 83% and specificity of 90%. The aim of our study was to evaluate our capacity to differentiate typicals from atypicals using DOTATATE and FDG PET scans by replicating the method used by Lococo. We chose to use surgical histopathology as the gold standard. We performed a retrospective review of our database for all patients who had a lobectomy or wedge resection for pulmonary carcinoid over 24 months beginning January 2019. We included patients who had a pre-op FDG DOTATATE or both scans that we had access to. The scans were reviewed qualitatively and quantitatively by 2 readers using Siemens Syngovia. External scans were reviewed qualitatively using Syngovia, and the SUV max coded in the report was used for quantitative purposes. For qualitative assessment, we scored the primary tumor as being FDG greater than DOTATATE or FDG less than DOTATATE after setting the display window at preset values of 0 to 15 for DOTATATE and 0 to 7 for FDG in accordance with the method for determining the net PET score. For quantitative assessment of the raw acquired studies, we determined the parameters listed on the right and compared typicals and atypicals on these parameters. In addition to Lococo's parameters, we also looked at primary tumor diameter. We scored the nodes qualitatively on Syngovia. We used a binomial scoring system, positive if the node was tracer avid and suspicious, negative if the node was tracer avid but not suspicious or not tracer avid. We used the formal histopathology reports as our gold standard and recorded the number of mitoses per 2 mm² and the Ki67 MIB1 percentage if these were coded in the report. For the SUV max, we did combined box and whisker plots to determine the median and interquartile ranges. For a quantitative comparison of SUV max between typicals and atypicals, we used the Mann-Whitney U-rank test. We had 25 participants in our study who ranged in age between 24 and 80 years with a mean age of 56 years. 23 were female and 2 were male. The majority of the participants had lobectomies, while 7 had wedge resections with distribution of disease spread among all segments of the lung. Among the 25 participants who had preoperative PET scans that we had access to, 17 had both FDG and GATATE scans, 6 had FDG only, and 2 had GATATE only. Apart from 7 FDG scans performed externally, the remainder were performed at the RAW. Among the 25 participants, 19 had typical and 6 had atypical carcinoids. We used the formal histopathology reports as the gold standard. In 13 of the 19 typicals, Ki67 was included in the report and all were under 5% as expected. Only 3 of the 6 atypicals had Ki67 in the report and all were less than 2% suggestive of low-grade disease. Of the 19 typicals, 2 had nodal metastases, and of the 6 atypicals, 1 had nodal metastatic disease. None had distant metastases. Among the 13 typicals with both scans, there were 4 who had an unexpected qualitative appearance of higher FDG avidity than GATATE. 1 out of the 4 ACs had an unexpected appearance of lower FDG avidity than GATATE. This participant had a typical carcinoid in the right middle lobe with avidity for FDG higher than GATATE. In the GATATE MIP display, the uptake is only visible with a lower SUV upper limit threshold. This participant had an atypical carcinoid in the left lower lobe with avidity for both radiotracers, higher for GATATE. With respect to our primary tumor quantitative assessment, we found that all of our SUV max comparisons between typicals and atypicals were not statistically significantly different. As mentioned earlier, Lococo found that a ratio of primary tumor GATATE SUV max over FDG SUV max greater than 1.19 would predict TC with a sensitivity of about 83% and specificity of 90%. Among our 4 participants with typical carcinoids who had the unexpected qualitative assessment finding of higher FDG avidity, the ratios were well under the threshold of 1.19. In our 1 participant with atypical carcinoid and the unexpected finding of higher GATATE avidity, the ratio was 4.8. 20 of our 25 participants had nodal sampling. 3 had metastases. Of the 3, 2 were typicals and 1 was atypical. All 3 had both FDG and GATATE scans. For both, FDG and GATATE specificity was high. Lococo showed that on qualitative assessment, tumor avidity for gallium dotapeptide and FDG was discriminative between typicals and atypicals. In our study, if the primary tumor was typical, we would be incorrect 31% of the time, and if it was atypical, we would be incorrect 25% of the time. Lococo also showed that if the primary tumor was avid for both types of radiotracer, a comparison of primary tumor SUV max with or without background correction with liver for FDG and spleen for gallium dotapeptide was discriminative between typicals and atypicals. We were unable to replicate the results and found no statistical difference in all our SUV max comparisons even when tumor diameter was taken into account. The ratio of primary tumor GATATE SUV max and FDG SUV max equal to or higher than 1.19 was also not found to be predictive of typicals in all cases. Among the typicals with the unexpected qualitative finding of higher primary tumor FDG than GATATE avidity, the ratios were below this threshold. In the 1 atypical where the tumor showed higher GATATE avidity than FDG, the ratio was above the threshold and not predictive. With respect to nodal assessment, the strength of both FDG and GATATE PET scans was in their specificity. Nodal reactivity is a common cause of radiotracer uptake in both FDG and GATATE scans. However, our false positive rates were still quite low, noted at 11% for FDG and 7% for GATATE. This may be a reflection of the low number of positive nodes, which in itself may be a reflection of the low grade of the primary tumors of our cohort. The nodal deposits may be microscopic, which limits the detection with PET. With respect to our study's strengths, we used surgical histopathology as the gold standard, which should be more reliable than biopsy. As well, all our surgical specimens were analyzed at one center, which would probably contribute to standardization of the gold standard. As ours was a single-center study, all of the gallium scans were performed with a singular radiopharmaceutical, GATATE. This would reduce the variability of scanning protocols and radiotracer pharmacokinetics, which can affect reproducibility of data, particularly with quantification of SUV max. Although the number of our participants was small, given the relative rarity of the diagnosis, to the best of our knowledge, it was comparable to the published literature, including our reference study. Our study's weaknesses included selection bias. By using surgical histopathology as the gold standard, this meant that the selection was biased towards the cohort with early-stage disease treated surgically with curative intent. Unavailable reports, the documented Ki-67 suggests that even among the atypicals, the tumor grade was low. Another weakness was that 7 FDG PETs were performed externally, which may have had implications for SUV max comparisons. These studies were reviewed qualitatively using Syngovia, thus the window preset values may not be strictly 0 to 7. Lastly, our study results were the consensus review of 2 readers using Syngovia. A comparison with the official reports for the PET scans was not conducted to evaluate for inter-observer concordance. In conclusion, in patients with pulmonary carcinoids using surgical histopathology as the gold standard, we found limitations in distinguishing typicals from atypicals on qualitative assessment of combined DOTATATE and FDG PET scans. SUV max was not found to be contributory. The strength of nodal assessment was in the specificity. However, our findings may be a result of selection bias of patients with early-stage disease treated surgically with curative intent. Thank you.